Let's talk a bit more in detail about the benzodiazepines. Please remember they all end with PAM or LAM, things like diazepam, triazolam, midazolam. And let's think about their mechanism of action. So they have actually a very specific, very interesting pharmacologic mechanism of action. They're so-called allosteric modulators at the GABA A receptor. So what does it mean? So they affect the GABA receptor, and where it's said this is this chloride channel, and it is a channel where GABA acts and binds. So here's a GABAergic neuron. So that's a GABAergic neuron, a releasing GABA. And the GABA is going to bind to a binding site here. So it's going to bind there. The channel is going to open. It's going to lead to hyperpolarization and then inhibition, CNS depression. So that's what GABA does. Now, what do the benzos do? They are allosteric modulators. So allos is Greek from different, so that means different, and steric means site. So they bind to a different site than the GABA. They actually bind to a different subunit in this chloride channel. So let's just suppose that's here. And that's the BDC, standing for benzodiazepine binding site. So they bind there, and then some conformational change happens, some magic happens, and then GABA can bind with higher affinity to the GABA receptor. And therefore this potentiates the GABAergic neuronal activity. So if you want to just summarize, so what happens step by step, so they bind to allosteric site, so different site on GABA A receptor, so that's their target. This increases the affinity of the GABA receptor for GABA. And then we get a potentiation of GABAergic inhibition of neuronal activity. So most of the time in pharmacology we are talking about agonists, or we're talking about antagonists, so drugs that stimulate or drugs that block a receptor, and that's different for the benzos. They are so-called allosteric modulators because they don't play around with the same site. They bind somewhere else, do some conformational change, and that changes how GABA interacts with this GABA receptor. Now the benzos are used for many, many different indications. We are discussing them now as drugs for insomnia, but we should not forget that there are many uses. We can also use them in anesthesiology, for anesthesia, for the same reasons. They make us sleepy. They also have anxiolytic properties, so they are used for anxiety. They're used for seizure disorders. We know there's a disbalance between too much activating and inhibitory neurotransmitters. So this is facilitating the major inhibitory neurotransmitter GABA. It's particularly used for something it's called status epilepticus. So a seizure activity that goes on for a longer period of time. Then we can use it for its spasmolytic activity in essential tremor, and also for spasticity. That's less well understood how that really works. But again, it's going to come up all the time, many indications for benzodiazepines. So when we are thinking about adverse effect, this is all predictable just by knowing that the GABAergic responses are potentiated. So how are we going to feel when we have all of this potentiation of this inhibitory neurotransmitter? Well, drowsy, confused. We can have anterograde amnesia. That means once we have taken this drug, we cannot recall facts as well. cannot remember things as well. Psychomotor impairment means just a slowing of thoughts and also movements. And then there's obviously the risk of substance use disorder. I mean, this is the same receptor, the GABA-A receptor, that also alcohol works on. So this is a similar scenario than when we are using alcohol. All the other effects. Also, this drug can cause tolerance. That means we need over the time more and more of this drug to get the same effect. Once we don't take this drug anymore, we can get a withdrawal. So when our body shows us physical dependence, so that we really need this drug. So there's the danger of developing substance use disorder when we take this drug for prolonged periods. So how do the benzodiazepines differ from each other? What makes us choose the one over the other? Well, we need to think about pharmacokinetics, about how they are metabolized. So almost all of them are fairly well absorbed. And then they are metabolized. We need to get rid of them at one point. And how do we do so? Well, most of them undergo phase 1 and phase 2 reactions. They both happen in the liver. So let's draw in here a little liver to remind us. So we're going to have phase 1 reactions, and this is mainly oxidation, and we have involvement of CYP enzymes. So they take care of that. And then they all undergo phase 2 reactions. The goal is to make these lipophilic molecules more water soluble so that we can excrete it. And so we're going to have with all of them glucuronidation. And then they are going to be inactive. And then we can excrete them via the kidney. So just to summarize, most of them undergo phase 1 and phase 2 reactions in the liver to make them really water soluble so we can excrete them via the kidney. However, I said most of them, not all of them, require this first step. There are a couple of exceptions. So there are some benzos that skip phase 1 reactions. They go directly to phase 2. They basically don't need the CYP enzymes. And these are some famous benzos that you should know. It's oxazepam, temazepam, and lorazepam. So why are they interesting to know? Well, they skip phase 1, and that means they are not going to be metabolized by CYP enzymes. So let's write safer in patients on other drugs that inhibit CYP so that you don't have any interactions. Safer in patients with liver disease and in elderly patients, because they also have at one point declining liver function. So in elderly patients. Now you might say, wait a second, this all happens in the liver. So why do we care so much about phase 1? Phase 2 also happens in the liver. Why should that be an advantage? Well, it just turns out that we have always access of these glucuronidation enzymes. But we have a limited amount of CYP enzymes. So if somebody has a decline in liver function, or elderly patients have a decline in liver function, or any liver disease, you're never going to feel it in the glucuronidation. You must be half dead to see a difference in glucuronidation enzymes. But you see a difference in the CYP enzymes. So don't be confused. The liver function really reflects in this phase 1 reactions and not in this phase 2 reactions. But these are a couple of that are handy to know. There's also a mnemonic outside the liver CYPs. So I'm going to write this outside the liver CYPs. Also, just to remember, it's not just outside the liver because we still have phase 2, but we have outside the liver CYPs. And they can come handy if you know those. Let's also talk about some interactions. So The benzodiazepines are characterized as CNS depressants because they depress the central nervous system, as well as alcohol, as well as the good old barbiturates. They have all a very similar mechanism of action, and they have all in common that they induce a dose-dependent CNS depression. So what does it mean? Well, if you have here a dose response curve, so dose on that axis, and then the degree of CNS depression on the y-axis, what you're going to see is with alcohol and barbiturates, they are more toxic, so you have really a straight line. And when we're thinking about the benzos, we're going to have more of this with a ceiling effect. So what type of CNS depression do we see? Well, it starts with sedation. Then we increase the dose hypnosis, which doesn't mean you hypnotize someone. It means inducing sleep, continuing with loss of consciousness. Anesthesia, coma, death. Let's put it that way. And what here you can clearly see, this is alcohol and barbiturates, that they have some overlapping effects, some very similar effects. The benzos are not as toxic because they have the ceiling effect. That's probably can be explained by their pharmacology, because they just do something so that this chloride channel opens better. Alcohol and barbiturate seem to be able to just open the chloride channel in very high concentrations. So they do the similar stuff than benzos in lower concentration, but at one point they just open the channel. And benzos don't seem to be able to do that. So that's why you get the ceiling, and for alcohol and barbiturate it goes a straight line. But they have all just a similar dose-dependent CNS depression, what you can see, and therefore it should make sense that you should not don't drink alcohol when taking these medications, taking benzos. Also don't take barbiturates, and also don't operate cars or heavy machinery when using these drugs. So as we're talking now more about also toxicity, I just want to re-emphasize that benzos alone are generally considered safe, but if you take them with alcohol, you're going to be on the straight line, and then they're obviously very dangerous drugs. Now, talking about overdose, we also should know that there is a benzodiazepine receptor antagonist, and that's called flumazenil. That's something you should have heard about. So flumazenil is a benzodiazepine receptor antagonist. So its mechanism of action, it's a competitive antagonist at the benzodiazepine binding site. So if you're thinking about this chloride channel, and that's kind of where our benzos are going to act, that's a BDC binding. Our flumazenil binds exactly the same site, so that's flumazenil. And that's also characteristic for a competitive antagonist. So you can use it as an antidote in a benzodiazepine overdose. However, usually you would just observe the patient unless it's very severe overdose. And where you're definitely going to see it used is in anesthesiology to reverse the effects of benzodiazepines. I also want to mention that it has a very short half-life, so you should not be surprised that you need to administer it over and over again, because depending on the benzo you used, can have a very long half-life, but none has such short half-lives like flumazenil, so it needs to be given in repeated doses. I want to finish up with some treatment principles just to summarize this section of benzodiazepines. So first of all, you should realize that there are many available. The selection is mainly based on pharmacokinetic differences, and here we are thinking mainly about short versus long half-lives. Many of the benzos have a long half-life and or active metabolites. There are a couple of exceptions and it may be worth to remember them. There's a nice mnemonic. They start with the letters of atom. So it's alprazolam, triazolam, oxazepam, and midazolam. These are the ones with short half-lives. So if you're thinking about short half-lives, this would be drugs that you would give to someone with, for example, a sleep onset insomnia, someone that tells you that they have trouble falling asleep, but they can maintain sleep. And they have a short half-life, so that has an advantage that they're not going to have a hangover the next morning. But be careful with drugs with short half-lives. They have a higher addiction potential, higher chance to develop substance use disorder because the levels are going to drop and fall also more suddenly, and that is going to favor physical dependence. Your body is going to show you that it needs a drug. And also you can more easier get something like a rebound insomnia. So if you stop the drug and you have the sudden fall, and then the body shows you that it needs it also by making you totally awake, so that you have this rebound insomnia. Always try to use them as short as possible because of substance use disorder. There are actually no studies that show that any effectiveness after 1 month. You should also taper them off after a month, and always consider age and hepatic function because most of them need to go while the SIP enzymes. This finishes the benzodiazepine section. We're going to now continue with other drugs to use in the treatment of insomnia.